everything that happens in Malaysia, once we've done that last year, currently as a different government this year. So, I mean, it doesn't put us down. We will continue to work hard to make this into a national agenda with also the help of other societies. So we understand that it's not feasible to work alone. So we work with other societies like the Malaysia Osteoporosis Society and also what we call the OASKLS, which is also the Patient Group Society, to form this Bone Health Alliance. So basically, the Bone Health Alliance was formed to improve the awareness of public in terms of bone health and also osteoporosis. So the activities were supposed to run this year. Unfortunately, because of COVID-19, there has to be a restructuring of how we want to engage the public, and there will be a lot of virtual platform where we're going to do this. So throughout the last 1.5 years, I would say, the FFN Malaysia has been doing a lot of education and training in different hospitals at different states to actually promote orthogeriatric care, to promote multidisciplinary care. And at the same time, we work with the Patient Group Society to help with public engagement, bone health assessment during the World Osteoporosis Day. Okay, you can all still hear me, right? Just checking.
Yes.
Okay, thank you. Okay, so this is just a little bit of intro, but actually I'll go straight on into this workshop. And this workshop involve a lot of interaction. That's why it's called a workshop. So I will have to get Dr. Terence to be my eyes and my ears to look into the chat function. So get ready. You're going to have to keep typing on the chat function of what you think you would do in this kind of scenarios, okay? Okay, so let's say I will present a case of this lady where it's not an uncommon scenario that you will see day in, day out as you practice, whether is it in the GP clinic or even in the hospital. Okay, let's see what you think about this case, okay? So you've got a 67-year-old lady who slipped and fell while she was shopping in Mid-Valley, and she sustained a soft tissue injury over her left ankle. She was already seen in the emergency department, and they said that, oh, you know, there was no fracture seen, it's likely a sprain injury. So they discharged her with analgesia. But because she's fallen before, and also because she's over 65, and as well as because we have such good promotion about falls and for our falls clinic, we've asked her to come to our falls clinic for further review. And at the same time, because of the research that we're doing, she was also enrolled. She was also asked to see if she wants to participate in the life study. So when she was seen in the falls clinic, one of the reasons of why she fell, we realized, was her improper footwear. So do make sure that when you assess a patient, it's from head to toe. Make sure you look at what footwear they're wearing as well. And but we couldn't find any other causes of why she fell, and that was the first fall. It was likely that she was unsteady wearing these very fancy slippers and fell down when there's so many people around. But at the same time, she asked this question. Well, she sort of just mentioned this. Oh, I'm glad I did not break my bones. So obviously that hit your mind, and you'll be thinking, oh yeah, what about her bones? She is 67. Would you want to check her bone mineral density, as in like, would you want to do a DEXA scan? So now it's your time to click either A or B, yes or no. Okay, I'll give you maybe 2 minutes to think about it. Well, I mean, you'll be thinking, oh, what's a bone mineral density? But it's okay. I mean, take a guess. We just want everyone to try and participate. Because when you participate, then the answers will stick to your mind more than if you don't participate. Okay, do we have anyone typing so far? Oh, are we extremely quiet at the chat?
No, they are typing away furiously. And the prevailing response seems to be yes, they will want to check her bone mineral density.
Oh, okay. So I guess some of you will say, yes, definitely. Or, you know, because this is a bone health workshop, isn't it? Or some of you may think, oh, no, I mean, you know, she doesn't really have any risk factor, you might be thinking. Okay, or some really clever ones might say, oh, actually, I think it's C. So it depends on what guidelines you're referring to. Okay, let's see what the guidelines talk about checking for bone assessment with a bone mineral density. So, I mean, there are two major guidelines. One is the more of a European one, which is the NOx study, the IOF one, where it actually suggests that every postmenopausal women and men aged above 50 years old should actually have their clinical risk factors. So the CRF is clinical risk factors identified. And after that, they should actually have a FRAX fracture probability assessed. And through that fracture probability assessment, then they would actually divide them into whether they have high risk, intermediate risk, or low risk before you consider doing a BMD scan. So this is basically talking about, oh, you need to do a risk assessment first rather than just straight going on to ordering DEXA scan. Whereas the American guideline, the National Osteoporosis Foundation, would say that, oh, yes, if anyone who is 65 years old and above or 70 years old and above, they should get a BMD testing regardless of any clinical risk factors, probably because they think that age is already a risk factor by itself. Whereas if you are below 65 for women or men, below 69 actually, then you have to think about the risk factor profile before you consider checking their BMD. So the answer is, it depends. All right, so there's neither really right or wrong, okay? Okay, so when you think about what actually is the diagnosis of osteoporosis, the WHO first published a diagnostic criteria back in 1994, and it says that, to diagnose osteoporosis with a BMD means that your bone mineral density T-score has to be less than 2.5. Okay, it'll be 2.5 or less, okay, negative 2.5 or less. And does bone mineral density actually predicts fracture risk? Then obviously it does. So if you look at this little graph here, you could see that, as your BMD T-score reduces, the probability of you having a fracture increases. And it increases even more with age as well. So consider if you're 50, 60, 70, or 80, the risk increases. Okay, sorry. And it increases twofold as well. Okay, so the other thing to look at is the NORA study. This is a study looking at close to 150,000 women, postmenopausal women. They followed them up to at least 1 year to see how many incident fracture do they find. So if you look at the fracture rate and the BMD score that they had, the higher the the lower the BMD score that there was, the rate of fracture increases. But then again, when you look at this solid black lines, this just tells you how many women actually had a fracture. But this one is the percentage, because there'll be a lot more women who actually had a T-score between -1 to -2.5. Just close to -2.5, and much less women within this range. But if you are within this range, your rate of fracture definitely is higher. But if you just calculate the number of women who just had a fracture, they are still quite high within the range where the WHO say is osteopenia rather than osteoporosis. So you have to understand that there is at least about 82% of fracture occurring in patients with T-score better than -2.5, okay? And a much smaller proportion at a lower T-score. So what does this tell us? I mean, it just tells you that the BMD is not the only risk of why someone gets an osteoporotic fracture. So you must think about other clinical risk factors. Okay, so to do a proper fracture risk assessment, not just about BMD, but also about their other clinical risk factors. Okay, let's have a look at this. So this one just tells you about the pathogenesis of osteoporotic related fractures. So it's not just about the BMD, but as you get older, you have higher increase in the rate of bone loss if you're postmenopausal, and it depends on what clinical risk factors you may have, and also people who have high bone turnover. So for example, people who are taking steroids, or those who are severely immobile, or people who's got Paget's disease, these rates actually increases. So increased bone loss causing low bone mineral density is one of the causes, but you have to think about the other causes, and the big ones here to look at is falls, okay? And also what type of falls that you've had will determine which part of the bones that you will fracture, okay? And when you couple skeletal fragility and also falls with excessive bone loading, that's when a fracture occurs. So this is just to highlight to you that, there are clinical factors for low BMD, but as well as also factors for falls and risk of falls. So that's a whole long list out there, including all the secondary causes of osteoporosis as well. So when you assess someone, remember to look at these factors. I've made age and previous adult fracture bold is because these two are much higher predictive of future fracture comparatively to the other clinical risk factors that you can see here. Which is why next I'd like to come to fracture assessment tools, just to introduce to you the FRAX and the OSTA. You may have heard of this before. This is the FRAX score. So you can actually go into the internet and look at the calculator of how they calculate it. And you come up with a 10-year probability of fracture risk, looking at the major osteoporotic fracture and also hip fracture. So you do not need a BMD score to actually do this calculator. You can actually leave it blank and it still calculates for you. And in the NOF guideline, it suggests that even without the BMD score, if your probability is more than 20% for major osteoporosis or hip fracture risk of more than 3%, that is an indication for osteoporotic treatment. Sorry, that's just part of it. Okay, yes, and in some of the country-specific FRAX score, they even come up with this graph that tells you what to do. So if you're in the red zone, then they suggest you treat. But if you're in the yellow zone, they suggest you measure the bone mineral density with a DEXA scan. Or if you're in the green zone, then it's really about lifestyle advice and treatment. Okay, so this is basically what's measured in your FRAX tool. So you insert your current age, gender, if you have previous osteoporotic fracture. This is what we're talking about, adult fracture. So any fracture that you have when you're age 50 and above, not fractures that you had when you're 13 years old, okay, that doesn't count. And also if you have your femoral neck BMD, you put it in, your body mass index, or if you are currently taking steroid tablets of 5 milligrams or more for 3 months or more, or if you have a doctor's diagnosis of rheumatoid arthritis, as well as any secondary causes of osteoporosis. For example, type 1 diabetes is in here, and all the lists that you can see. Or if you have a parental history of hip fracture, current smoker, or alcohol intake. Okay, so every risk assessment score also has its limitation, and this is part of the limitation of FRAX, because it does underestimate the dose dependent variables. So for example, if you smoke a lot, your risk is actually much higher than if you just smoke less, as well as alcohol. If you have multiple fractures, that means you fractured your wrist before, you fractured your spine, you fractured your hip, the risk is much higher. But it doesn't translate to that when you actually put it into the FRAX, okay? Or the dose of your steroid tablets that you take also increases your risk. So if you take 7.5 milligrams or more, that is considered as a high dose of corticosteroid usage, okay? And the other thing is that, yeah, it doesn't accommodate whether you've had multiple falls or what your bone turnover markers are, or if you've had a recent fracture, because everyone who's had a recent fracture has a much higher risk of developing a next fracture compared to if your fracture was 5 years ago. Or type 2 diabetes is actually also not included in the fracture risk assessment. So it may also underestimate your risk if you've got previous clinical vertebral fracture, because when you've had a vertebral fracture, your risk of having another vertebral fracture is actually very high. The other thing is that what if your T-score for your lumbar spine is actually very low, but your hip T-score is not as low. So that is not being calculated in your FRAX. So doing a FRAX does not replace your clinical judgment. Okay, this is just to tell you that, if you've had one fracture, the risk of you getting a subsequent fracture is much higher. So for example, just to highlight here, if you've had a spine fracture, your risk of getting a subsequent spine fracture is at least 4.4 times higher risk compared to someone who's not fractured a spine before. The same goes for hip or future hip fracture. Okay, so also to introduce to you another type of risk assessment tool. This is the OSTA. So the OSTA is actually one of the risk assessment that incorporates mostly Asians, but it's only for Asian women. And this is less taxing to do. You can even do it when you don't have an internet connection, because it only actually looks at the age and the weight, and it just also gives you the assessment of whether is this a high risk, medium risk, or low risk. So this is actually sometimes quite good to use, especially if you want to do a public engagement or a roadshow. So that's quite quick. Okay, but it's mainly for Asian women. So there are different cutoffs for men. So if you do this, if you just put it particularly for men, it may not be as accurate. Okay. Okay, so case number 2, I'm just conscious of time. Okay, so next case, you have a 74-year-old Indian lady that comes to the geriatric clinic for follow-up. So she's actually recently discharged from the geriatric ward because of a urinary tract infection. And when you look at her history, she has a history of rheumatoid arthritis, depression, and ischemic heart disease. And after she's been discharged, after staying in the ward for 10 days or so, she's now less mobile. And she requires assistance because she's a bit unstable, lying in the hospital for quite about a week or so. But she's not actually fallen. And on your right-hand side is the list of medication that she's taking. So there's aspirin, omeprazole, methotrexate, escitalopram, simvastatin, and some calcium and rocoutril. So when you look through and you thought that, although she's not fallen, but she does have a risk of falls. And at the same time, when you look at her other investigations that she's done in the past, you found this in one of the in her notes, that she previously had a T-score of her femur of -1.6 and a T-score of a spine of -2.0. So what do you think? You talked about, okay, maybe I just have a look at her risk factor for osteoporosis. She does have, she's a woman, she's older women, she's got rheumatoid arthritis, and she actually does take medication that are associated with osteoporosis, higher risk of osteoporosis, like your SSRI and your methotrexate. And she does have a high risk of falls as well, because she's unsteady and she is above 65 years old. So when you put, as we talk about FRAX, you put all the variables into the FRAX and you wanted to calculate. And when you calculate it, you were like, okay, I even have a T-score for her femur, but her major osteoporotic risk is only 11% and hip fracture risk is 2.7%. So what do you think? So she's considered as having osteopenia, osteoporosis, or not sure yet? Would you consider starting her on osteoporotic medication? Okay, now it's time for you to type again.
This is the perils of doing online webinars.
Everyone is waiting for the other person to type first. Any takers?
Yes.
Any answers?
So we've had a few answers now, and C, we've got a few C's, a couple of, we've got osteoporosis, we've got an osteopenia as well.
Okay.
Osteopenia. So yeah, I think there's a mixture of answers.
Okay. Well, I mean, from what you can see, if you depend, okay, as you can see, because we don't have a Malaysian FRAX data, so that's why we use Singapore Indian data. And if you look at the FRAX, and when you want to look at the 10-year probability risk, she's not really that high on here. But at the same time, if you want to depend on WHO classification or diagnostic criteria for osteoporosis, she's only negative 1.6. So you can say that, oh, maybe she's only got osteopenia. But like I say, this is actually just looking at the BMD score. So you have to think about her other clinical risk factors, which we've highlighted. She's got lots of risk factors for osteoporosis. But is there any other assessment that you can do to determine how healthy or how unhealthy or how high risk she is in developing a fracture? Does anyone know? What are the other investigation, or what else do you want to do? Because, you know, if, like what I've mentioned earlier, if she's had a previous fracture, the risk of her getting a future fracture will be very high. So what type of fracture do you think? What type of osteoporotic fracture do you think, which is mostly silent, and even when you have had a fracture on that area, you may not know, and it's quite easy to find out? Does anybody want to give a try? Okay, never mind. I'll give the answer. Okay. So how else can you assess her risk? So there's another thing that you can do, vertebra imaging. So can anyone tell me what you find on this lateral lumbar spine X-ray? Okay, no answers. Okay, let me show you. Oops, sorry. I guess the circle should have gone upwards a bit. So this, okay, maybe like that. So this is the area of the compression fracture. So this lady has actually had a previous fracture before, so, but it's probably silent and she didn't know about it. So having had a previous fracture, or even having had a previous vertebral fracture, this person is considered to have osteoporosis, despite whatever the BMD score says. And it's important to note, because vertebral fracture is one of the commonest fragility fracture, and only about a third is actually clinically diagnosed. And you remember that, you know, vertebral fracture, although silent, it is associated with high morbidity and mortality risks. You know, people get severe back pain, and they may get problems with their respiration because of the kyphosis that occurs with it. So, and a lot of reports that, you know, people who've had vertebral fracture actually has increased dependency in their ADLs, and also in worsening of their psychosocial health aspect as well. And whether is it just a radiographic diagnosis of vertebral fracture, or actually a clinical vertebral fracture, the risk of future fracture is increased. Okay, so this is the NOF guide that suggests that, you know, a vertebral fracture assessment, either by doing a lumbar spine X-ray or actually getting a DEXA, and I can actually show your vertebral spine height, and also to see if there's any fracture in there. I'm not quite sure if the one that in UM, whether we can do it or not. I think we can, but I've never really seen it being done before. Yeah, so in the NOF guide, it suggests that, you know, all women age 70 and all men age 80 and above, if their T-score is less than 1, that means, less than negative 1, less than negative 1.0, they should have a fracture, a vertebral fracture assessment. And for any women age 65 to 69, or men age 70 to 79, if their T-score is less than negative 1.5, then they should have a vertebral fracture assessment. And for postmenopausal women and men age 50 years and above, if they already have specific risk factor as the following, they should also have a vertebral fracture assessment. For example, if they've previously had a low trauma fracture elsewhere, doesn't matter whether it's the hand, the feet, or anywhere else, or if they have had a history of height loss of 4 centimeters or more, or prospective height loss of 2 centimeters or more, or if they are currently on steroid tablets, then they should have a vertebral fracture assessment. Okay, so this is just to highlight to you the CPG, our Malaysia Osteoporosis CPG, treatment guidelines for osteoporosis. So any postmenopausal women or men, which is 50 years and older, who've had a hip or spine fracture should be started on osteoporosis treatment, or if they have a DEXA scan of T-score of less than negative 2.5, they should be started on treatment. Or if your bone mineral density is at the osteopenia range, and like what I've mentioned, your FRAX actually shows that your major osteoporosis risk is more than 20%, or your hip fracture risk is more than 3%, then they should be considered for treatment. Okay, I've already taken half an hour of the time, so I think I'm going to end here and let Dr. Terence continue this session.
Okay, all right. I'm going to do the really annoying thing and say, wait, let me slides.
Okay. While we are waiting, does anyone have any questions at all at the time being? Okay, so if you're really shy, you don't want to ask any questions, you can ask questions at the end of this workshop as well.
Okay, so I have been given the not very envious task of trying to sum up what we can do to reduce fractures in a group of older people who are at risk of falls. Okay, so to set the scene, we're going to start with Mrs. Kim and her daughter, because usually older people, when they come to clinic, there is usually a family member accompanying them. So we've got Mrs. Kim. She's 78 years old. She's seen in the medical clinic, let's call it the Falls Clinic, 6 weeks after her discharge with a fall and a left humerus fracture. She's recovering well. She's had no further falls. Her arm is still in a brace, and she's getting ongoing orthopedic follow-up. Her chronic medical issues, hypertension, diabetes have all been addressed during her admission, and there is nothing else that needs rectifying. So the daughter says, right, my mom has had many falls. Please help. I'm scared she will fall again, break more bones, and hurt herself. Okay? So we'll start off with a question. Falls-related fractures can be prevented. Can you suggest some evidence-based intervention to prevent them? Okay? Chat function away.
Okay. Falls-related prevention.
Okay.
I think everybody is a bit shy still. Okay, balance exercise. Yeah, we just had that talk.
I mean, one of my suggestion was you bubble wrap Mrs. Kim like that, and you label her fragile. That might be one particular intervention. Okay. I wrote a list. Okay. And this is a list of what I can come up with that is out there. Some with perhaps more robust evidence, some with very little evidence, but all seem to purport some benefit in fracture reduction. So we won't go through each and every one of them because that's a bit too many, but we'll just highlight a few for today's discussion. Okay. Now, because at the end of the day, and this is a point that Dr. Khor and Prof. Tan and some of the speakers earlier have already hammered down. See, to prevent fractures, two things have to happen. One is to try and stop the fall, the traumatic event, the precipitant to the fracture. And the second thing that needs to happen is to ensure that, let's say, if a fall did occur, that the bone is less susceptible to breaking. Okay? And what you've got here, this picture here, is a cross-section of a vertebra that is porous. It's got many holes in there. Okay? And this is a cross-section of a vertebra that has osteoporosis. Okay? So strategies to reduce fractures is very much trying to stop older people from falling, and also making sure that if they did fall, that their bones are not susceptible to breaking. Simple. Okay? So there's another question for you. Okay? We've sort of covered a lot during the course of today, and well done for persevering up till this point, that the way we address falls, the way we reduce falls, is by a multifactorial falls risk intervention, looking at polypharmacy, looking at muscle strength, looking at different aspects, different risk factors to try and minimize the future risk of falling. And we recognize that this type of management is the gold standard to prevent falls. So my question to the many of you here is, do you think that doing all this actually reduces fractures? So 4 options. Yes, definitely. Yes, most likely. The evidence is a bit inconclusive, right? Or no, it does not.
Yeah, type away. We'll all have to be decisive. Okay, we've got an answer. Yes, most likely. Any more? Oh, okay, some more. So we've got, mostly people have mentioned number 2. Yes, most likely.
Okay. Now, unfortunately, the evidence is a little bit disappointing. Okay. And to date, this is perhaps the most robust systematic review meta-analysis that has been done. Okay. So this was a Cochrane review that was done about 8 years ago, and they looked at 40 different multifactorial intervention studies. Now, not all 40 studies looked at fracture as an outcome. Okay, majority looked at falls as an outcome, but there were about 11 studies here that looked at fracture as a secondary outcome, and the results were a bit disappointing. Okay, in a sense that the answer was a multifactorial intervention did not reduce the risk of fractures compared to a control group. But looking at it in a little bit more detail, the first thing to say is that multifactorial falls risk intervention were never designed to reduce fractures. It wasn't what these studies were designed to do. They were designed to look at, can we reduce falls? So they were already underpowered to detect any effect size at reducing fractures. The other challenge with these types of studies is its degree of heterogeneity. These studies were very, very different. Some of them very different. Some had different participants. So some excluded those with cognitive impairment. Some included those with cognitive impairment. Some look at community dwellers. Some look at care home residents. Different levels of compliance were reported with participants engaging in the intervention. The multifactorial false risk interventions were slightly different, looking at depending on which study. And perhaps one of the biggest elements to many of these multifactorial false risk intervention is that the majority did not have an explicit bone health component. Not many of them, as part of their multifactorial false risk intervention, actually looked at risk of fracture, which is why it is unsurprising that we get a forest plot that didn't show any difference. Which is why it's exciting to see papers like this. So this came out a year ago now, and it's a pretty good multifactorial false risk intervention done in Australia, where they had a very big component on prevention of fractures. So every patient will risk assess. If your risk was high, they had a bone mineral density assessed, and if that showed that you were at risk of a fragility fracture, they were started on treatment. And this was part of their falls program. Okay? And in this particular study, they did report fewer fractures as a secondary outcome. But perhaps this is the one that many are most looking forward to. Excuse me. So this is a study called PREFIT. And the reason why I'm certainly excited about it is because this is the first study that's been adequately powered to look at multifactorial falls risk intervention to reduce fractures. So fractures have now become the primary outcome. And what's amazing about this is the plan, and they have succeeded, is to recruit 9,000 participants. No falls intervention will ever be able to recruit 9,000 participants. They did. Okay? So we wait with bated breath whether such an intervention actually will reduce fractures. The protocol is there. It's open access, BMJ open, if you're keen to look at how they did it. So that's a brief overview about multifactorial falls risk intervention. It doesn't mean that it doesn't reduce fractures, but there are certainly caveats to the evidence that we have so far. But if we look at perhaps the biggest component of this multifactorial falls risk intervention, which is exercise, can exercise alone do anything about your bone health? So, question to the floor, question to the group of you. Can exercise reduce falls, improve bone mineral density, prevent fractures, facilitate recovery, or all of the above? So 1 to 5, what do you think?
Okay.
If you can give me the name and the achievement of this older gentleman, you get a virtual thumbs up from me. All right. So
We've got a lot of 5s.
You've got a lot of 5s. Okay.
Yeah, it's a leading question.
Did anyone manage to get the name and the achievement of this gentleman?
Oh no, I haven't got any takers yet. I must have done a marathon or something. Triathlon.
Actually, he's more impressive than that. So
Oh
this
dear. Okay.
is Mr. Inada. So Mr. Inada is Japanese. At the young age of 85 years old, he became the oldest person to complete an Ironman challenge. Okay, what is an Ironman challenge, you ask? So an Ironman challenge involves, and I wrote this down here, being able to swim 3.9 kilometers, cycle 180 kilometers, and run a full marathon. And he did all that at a very young age of 85, which sort of puts me to shame, really, because I get breathless going from one floor to the other on the stairs. Okay, so is the answers to all of the above then, okay? So it is a slightly leading question, okay? So we know that exercise does improve bone mineral density. Bone exercise does reduce fractures. And it does facilitate recovery after fractures, although much of it is of low quality evidence. But exercise seems to deliver lots of good things for your bones. Okay? And I believe the slides will be shared and presentation is recorded. So in a nutshell, it does do lots of good things for your bones. But then the question, which we sort of explored in the last session, is that exercise is a myriad of things. Okay? My dad walks around his taman and he calls that exercise. And I tell him, no, that is not exercise. Okay? So if we want to talk about optimizing bone health and reducing fractures, what is the exercise prescription that is required? Okay? So this lady, she is also as impressive as Mr. Inada. She's got a nickname, and it's called the Iron Nun. Nun because she is a nun. She is an Italian Roman Catholic nun who has completed lots of triathlons and lots of Iron Women challenges. Okay, but there was a problem. After she passed the age of 80, she became ineligible to join further Ironman challenges. So she not complained, but she requested very kindly that those over the age of 80 continued to be allowed in Ironman Women challenges. And she was successful. So at the age of 82, She completed an Ironman challenge after advocating for it to be open to those over the age of 80. Impressive indeed. So what is an effective exercise prescription to optimize bone health? Now, first thing to say is that bone is an active tissue. It's continuously remodeling, which responds to dynamic, intermittent mechanical loading. So what it means is, like a drug, as long as you continue to take the drug, and in this case, do the exercise, it does good things for your bone. Stop doing the exercise, doesn't deliver the benefit. And the exercise needs to be resistant training in nature. Okay, so you have to work towards some sort of resistance, whether that be a tension band or one of those rowing machines. There must be some form of weight bearing. Okay, weight bearing on the bone. It has to be high impact. High impact meaning how many repetitions can you do in a minute or 5 minutes. It has to be quick. Okay, and to get the benefit, the consensus seemed to be doing the exercise for at least 6 months. Okay, to see any benefit, 6 months seemed to be the average of how long you need to carry on doing it for it to translate into bone health benefits. And here's also another very important point. Okay, and it's the worry and the fear of doing exercise. Exercise does not increase your risk of fractures. There is a systematic review reference that I've inserted here. It doesn't increase your risk of fractures. Okay? And there have not been any reported side effects from doing exercise, certainly in the scientific literature. Okay? So exercise is pretty safe. It may make you feel tired, but it does a whole lot of good if you're talking specifically about bone health. Okay? So some pictures here of what resistance and weight training looks like. There are tons of literature on exercises that you can do. I like this one here called Too Fit to Fall or Fracture. It's put together very well by Osteoporosis Canada. If reading literature isn't something that you like, there are videos. So this is the UK Royal Osteoporosis Society's website. On top of a literature fact sheet, they have videos as well of exercises that you can do, which incorporated all those elements I was alluding to. Okay. Now this is something that, so if you were a gym member, let me rephrase that. If before MCO you were a gym member in one of these high-end gyms, you probably have seen equipment like this. Okay, this is a whole body vibration plate, and it's quite exciting really because it's getting quite a bit of traction as an equipment that can improve bone health. Okay, now not to be confused with what we call a low body vibration plate, where you just have the foot thing. This one you have the handles as well that you can hold on to as you stand on it. Okay, but there is certainly emerging literature that it stimulates bone formation, improves BND, and if you do whole body vibration on top of taking osteoporosis drugs, it accentuates the effect of the drug itself. It's an emerging therapy, so there are no large-scale studies to date. And what researchers have yet to agree on is this, what I call a vibration prescription. How long do you have to be on it? What is the frequency of the vibration? What is the amplitude of it? So there are still some uncertainties around this as a tool, but the only thing I would say is watch this space. But the important point that I highlighted right at the bottom there is great, absolutely brilliant that it improves BND. But how much of this improvement actually translates into fracture reduction remains unknown. Okay, so exciting stuff, watch this space. Now, hip protectors, they are not very flattering. It's not very pretty, and it looks like that. It's a tight undergarment with foam or plastic protectors. Okay, do they work? Well, the evidence seems to suggest it does. Certainly, especially if you live in a care home setting. Pretty good at preventing hip or pelvic fractures. Doesn't stop you falling, doesn't stop you breaking other fractures, but certainly pretty good at preventing hip and pelvic fractures. The problem with that is that it's really, really tight, really annoying to be worn, which is why adherence is very, very poor. Okay? If older people do wear it, certainly the evidence coming from very much Western Europe and white Caucasian countries is it does work. And then I came across this video. So let's see how this goes. It should play with audio.
So CES has barely begun and we're already seeing tons of assistive tech for elderly people. This product is called Hip Air and is essentially an airbag for yourself. So the Hip Air is essentially a wearable airbag. It weighs about 2 pounds and you attach it to yourself like a belt. It's really targeted for elderly people and their families to give you peace of mind that if someone who's frail takes a fall, they're not going to break their hip and have to spend months and thousands of dollars in hospital. So how it works is there are gyroscopes and various sensors inside, and as soon as it detects someone taking a fall, it will deploy 2 airbags just like you would have in your car. So it's going to come out in Europe quite soon for $790 and then come to America later this year. On top of the $790, every time someone takes a fall, which hopefully won't be too often, you have to pay another $50 to replace the gas. That might seem quite expensive, but I think for people that want that peace of mind, it will probably be worth any amount of money.
So essentially a human airbag. Whether it's worth $800 or not is certainly up to debate, but the idea of incorporating technology into fracture prevention, I think, is a very exciting idea. Okay, so we've come back to Mrs. Kim and her daughter, and the question I want to put forth to you guys is, should Mrs. Kim be started on osteoporosis treatment? Remember, she's a 78-year-old lady, fell and fractured her humerus. This is a past medical history. She's got no renal impairment. What do you think? 1, 2, 5.
Okay. I think people are thinking.
Thinking, yes. Would you pay $800 for a human airbag with me?
800 ringgit, yes, definitely, to be honest. But euro, I'm not sure. But I think if it does prevent, it really sounds like a very interesting gadget, you know. Okay, let's see. We have one answer. I mean, the rest are not really wanting to commit, which is Jen Xiang. Jen Xiang has been very active. The answer is number 4. Get a DEXA scan first to assess her BND. Okay, there are other answers. Number 1, yes, with oral bisphosphonate like alendronate. And oh well, there are a few more 3s coming. Yes, with calcium and vitamin D supplementation. Okay.
Okay, right. So we've got, again, a mixture of answers. I can't remember what. Oh, yes, here we go. What would you do, Hui Min?
I think if she's never been treated before, I would go with 1.
Yeah, I'm certainly also leaning towards one as well, and I will try and explain why that might be the preferred option. So now, I was conscious to not turn this session into a talk on osteoporosis drugs, because that would take us way into the evening. Okay, but this is the options that we have in terms of treatment for osteoporosis. Okay, and regardless of agent, they all work. Okay? Whether it's an oral bisphosphonate, whether it's an IV drug, treatment for osteoporosis reduces fractures. Okay? Which is why the issue no longer becomes which drug, but to make sure that those that you think would benefit from treatment gets access to treatment. Okay? Now, this document Dr. Khor has already brought up. It is our Malaysian local clinical practice guideline for osteoporosis. 2012, it was updated in 2015. Okay? But there are a few principles that we can take away from it. Okay? First, if you have osteoporosis, you treat. If it's osteopenia with a fragility fracture, treatment is recommended. If they have osteopenia, treatment may or may not be required depending on the existence of other risk factors. To know and to guide which way we go, risk stratification tools are very helpful, which tells us treat, don't treat, do a DEXA scan, don't do a DEXA scan. And someone like Mrs. Kim, if you put her through one of these risk stratification tools, she will come up as requiring treatment. Age, gender, and an existing fragility fractures itself are risk factors that will require treatment. And in terms of what we prescribe, generally, oral bisphosphonates are first line, and if there is intolerance or a contraindication, or perhaps a lack of response to the oral bisphosphonate, then parenteral, whether it's subcuts or intravenous options, would be the second line. But the key thing here is to always remember that osteoporosis is a chronic disease. And like any chronic disease, requires some form of monitoring to ensure that the chronic disease doesn't get worse. Because remember, heart failure presents with acute pulmonary edema. Chronic kidney disease presents with acute kidney injuries. Chronic osteoporosis' complication would be further fragility fractures. And we're in the business of trying to prevent that from happening. So monitoring of osteoporosis has to be embedded as part of fracture risk reduction. And working alongside specialists as required, if required, is part of that management profile. Okay. So it's all well and good say, right, let's start Mrs. Kim on an oral bisphosphonate, say alendronate. Question for you guys back again. Okay. What percentage of people prescribed an oral osteoporosis drug would still be taking it at 12 months?
Okay. Well, let's see what people put. Well, I know we've got a few pharmacists here as well, isn't it? Okay, I've got some say 0%.
A very pessimistic person.
Some say for number 2. Oh, wow, we've got every answer. 1, 2, 3, 4.
I mean, to be honest with you, it very much depends on which study you want to quote, which country you want to quote, which healthcare system you want to quote. Okay, so I'm going to pinch this one. Okay, so this is data from the UK General Practice Research Database. So almost everything in primary care in the UK is coded and tracked and recorded, and a good proportion of it gets contributed to a research database. Okay, and what this study reports is actually not too dissimilar to what has been reported in other similar countries like the UK, okay, US or Australia. At about 12 months, so here's my cursor, here we go, about only 50% of patients prescribed an osteoporosis drug persists with your medication. Okay? And if you've ever seen anyone take an osteoporosis, like an oral bisphosphonate, it's not the most straightforward thing to do. Why? You have to take it on an empty stomach, first thing in the morning, before breakfast, nothing to eat after that. The tablet itself isn't the easiest to go down, okay? Which is why it has to be taken set upright, okay? There are many things about oral bisphosphonate that isn't the most user-friendly, okay? And this is before you factor in side effects, okay? But all in all, we know that majority of patients who start on an oral bisphosphonate sadly do not persist with taking them. There becomes a big problem. Okay. We know that taking the drug helps, and if you don't take the drug, it's not going to help. So part of what has to be embedded into osteoporosis and fracture risk reduction management is some way of making sure that patients continue to take what they are supposed to take, or if they're unable to take it, some way of reassessing and reviewing treatment need. Okay? So calcium and vitamin D. This in itself it's a bit of a minefield. Okay? So I'll start by what we know already. We know that calcium and vitamin D intake is key to optimal bone health. Okay? And in Malaysia, we do not have a calcium-rich diet. Okay, a report from the Ministry of Health in 2017 says that on average, Malaysians consume about 350 milligrams of calcium a day, way, way, way below the recommended daily nutritional intake. Malaysians are also vitamin D deficient in general. So I've just picked the Malaya study because I had a feeling Prof. Tan was going to use it as an example early in the day, and which she did. So the Malaya study showed that about 40% of its participants were vitamin D deficient. Okay? And the recommended daily intake of vitamin D is 800 international units or 20 micrograms, depending on the unit of preference. Okay? So we're not good at vitamin D and calcium in Malaysia in general. But does taking calcium and vitamin D reduce fractures? Now, I'm not talking about improving bone mineral density. I'm not talking about preventing falls. I'm saying, does prescribing calcium and vitamin D reduce fractures? Okay? And this is where there is huge disagreement in the literature. You Google calcium, vitamin D, and fractures, you will get as many papers that say it does, and as many papers that say it doesn't, because of many things. They were done in different settings, with different dose, different duration. They were different participants. And some studies didn't confirm for whether the patients were taking over-the-counter supplementation. Okay? So many disagree on whether calcium and vitamin D reduce fractures, which is why prescribing at the population level is unlikely to reduce fractures. Okay? Prescribing calcium and vitamin D to everyone who has fallen, every older person, is unlikely to reduce fractures. Okay? Unlikely as a single intervention, I must quickly add. But, okay, when the data is looked at in a little bit more detail, there are certain groups that do seem to benefit from fracture reduction with calcium and vitamin D supplementation. First one is those that are deficient. So if you've got low calcium, low vitamin D, replacing that does seem to reduce the risk of fractures. Older people who fall, who are unable to meet the daily RNI requirement, give them calcium and vitamin D supplementation, there seem to be suggestions that it does reduce fractures. care home setting, okay, there is certainly good evidence that calcium vitamin D does reduce fractures. Okay? So the question of whether calcium vitamin D reduces fractures or not very much depends on the population that you are giving it to. And these are the ones that seem to suggest would most likely derive a benefit. Okay? And the other way to look at it as well is all osteoporosis drug trials included calcium and vitamin D as part of their treatment regime. It all came as a package. So if you're an evidence-based medicine purist, you're going to say that all alendronate, all resedronate, all drugs should be co-prescribed calcium and vitamin D supplement. Okay. And also a quick point at the bottom, giving calcium and vitamin D alone, there is no robust evidence that that on its own, calcium or vitamin D, reduces fractures. So if you want to know whether you're having enough calcium or not, Google calcium calculator, you get a ton of them that come up. I've just pinched this one from the International Osteoporosis Foundation website. Okay. So if the aim is to reduce fractures in someone with or suspected with osteoporosis, then bisphosphonates as first line with calcium and vitamin D supplementation is the way forward. And I think this is my last question because I'm conscious of time. Okay, and also the last point that I want to hopefully get across. So the risk of a subsequent fracture is high after an initial fracture. We saw that table that Dr. Khor had about how having an existing fracture increases your risk of another fracture. But we know that fracture risk isn't linear, meaning that your risk of another fracture is different at different points in time after the index fracture. So my question to you is, when do you think this risk is highest? Does it peak at 3 years after the fracture? Does it peak at 2 years after the fracture? Does it peak at 1 year after the fracture? Or does it peak at 6 months after the fracture?
Okay. Okay, we've got we've got a 4, we've got a few 3s. So mostly people are gearing towards 3 and 4.
Okay.
Oh yeah, lots coming. Yeah, lots of 3.
And I'm pleased that this is I'm pleased that this is a point that you've already grasped. Because if you had a fall and then you had a fracture, your risk of another fracture peaks dramatically within the first 12 months after the index fracture. And the reason this point is so important is that it's not something that you can sit on and wait. See how? No. An older person who fell and broke a bone, there is a sense of urgency to address your risk of falls and your risk of fractures. Why? And it makes intuitive sense. If there was a precipitant to the fall and the fracture, that risk is still going to be there unless you address it. Okay? If they cannot see because they have a problem with their vision, you need to address that sooner rather than later. If they're falling because they're on lots of benzodiazepines, that has to be addressed, which is why the risk of another fracture is so high immediately, or not immediately, but certainly within the first 12 months of the index fracture. So fracture prevention has to have that sense of urgency. Okay? Because if not, we've missed the boat. So, in summary, older people are at risk of falls, also need to have their fracture risk addressed. There are effective interventions to reduce fracture risks among older people who fall. Strategies are targeted at falls reduction and improving bone mineral density, i.e. treat osteoporosis. It has to be delivered as soon as fracture has occurred. And it's one that's pretty exciting because you can start to see some of this evidence-based growing and evolving. Vibration therapy is an exciting one. The role of calcium and vitamin D has gone through many different iterations from yes it does, no it doesn't, yes it does, maybe it doesn't. Okay? So I will perhaps end at this point, and certainly open it up to the floor for any further questions or clarification about either Dr. Khor's or what I've just shared.
Okay, so we actually had a question earlier from Gordon. Gordon, if you're around, maybe you want to unmute yourself and ask your question.
Hi, thanks, Khor. So, question to Dr. Khor, Dr. Terence. Apart from vitamin active D3, are there good evidence of other form of vitamin D like calcitriol?
D3.
So I think the problem is that in the university hospital or maybe even in KKM hospital, if anyone's working from there, many times the prescription is actually directly calcitriol, like the Rocaltrol that we always prescribe because it's actually under the government formulary. So I think Gordon wants to ask which types are better, what's the evidence behind all these different types of vitamin E that is being provided.
The short answer is, I think the evidence seems to suggest D3 is better than D2. And oral seems to be better than IM. So which is why we still prescribe oral vitamin D3 in many of our patients.
Yeah. Let me see. Well, earlier there was a question about the height measurement. What does it mean by prospective height loss? So basically I've mentioned that usually what you do is, your patients come to you in clinic, you measure their height. If subsequently their height has reduced, then that's what really prospective height loss means. But I have to say, saying so, even though I say so, I really cannot remember when our patients actually really had a height measurement. And even in our geriatric clinic, we don't even have the standometer to measure their height.
Can I, so there's a way to go around it. And there's a group in Bristol where they have used something called a rib pelvis distance. Okay, so if you Google rib pelvis distance, and they have got a cutoff score, and if you are below a certain measurement, it does indicate that you have lost height. And it's pretty validated. So Google rib pelvis distance, and that was one way they went around to asking the person if you lost height. Because you're right, most people would say maybe, yes, no, don't know. Yeah.
Yeah, that's a good way, because I think at least there's an alternative. Otherwise, there are a lot more other patients who actually are not really mobile to stand up and stuff like that. Okay, let's see. Are there any other questions? Because we only have like 2 more minutes before we have to go back to the main region. Oh, let's see. Oh, we've got one question here. Do patients need to stop taking calcium supplement for 3 days prior to DEXA scan? There are some hospitals that apply this protocol. Well, I have to say that in UMMC, we actually do ask the patients to stop taking calcium supplements, calcium and vitamin D supplements actually. Can't remember how many days. I think, about 3 to 5 days before doing the DEXA scan.
Why?
That's a good question. That's why I stopped there. I'm not quite sure how this will interfere the assessment, but yeah, I don't know, to be very honest. You have any thoughts? But that's what UM does.
Perhaps this is something that we can look into. I cannot sense the rationale, because if you think of how DEXAs work, so DEXAs work by essentially shining a fancy X-ray through your body, and it measures calcium deposition. Okay, And that's calcium deposition through bone. If you've got vascular calcification of the aorta, it measures that. If you've got bony spurs at your spine, it measures that. So it measures calcium deposition across that field of radiation. I cannot see how stopping calcium supplements 3 days before your DEXA would affect quantifying the amount of calcium you have between the between your body. So it's why I cannot see how that would affect your reading. Okay. And I think this is something that perhaps we may want to look into.
I mean, I don't know. I mean, well, when you're doing webinar, it gives you time to go and Google some sort of things out. So when I'm just trying to Google it, some people, I mean, one of the answers were like, it sort of said that if calcium supplement is not completely dissolved, it will be interpreted by the DEXA instrument as extra bone and may produce an inaccurate reading. So I'm not quite sure whether they think that if it's not dissolved in your stomach, it would actually look as though the spine area has extra bone. I'm not quite sure, to be honest. I don't know.
I cannot comment on that.
Okay.
Because then the question is, why do you have to stop it for 3 days, not for just the morning in itself? So I'm still not entirely sure about this, but perhaps there's something that we can.
Is that a protocol in the hospital that you used to work in before?
No.
No, okay. We've got another question. Are there any specific reasons that most women do not persist with osteoporosis medication, such as side effects? Oh, okay. So, well, I mean, I guess that's a whole long list of reasons why people do not persist with the medication. Sometimes a lot of it may be because of the education. They weren't quite told why they're taking it. Some of them may thought that, I've taken it for a year or 2 years. Do I really have to persist with it? It may be because they're not quite sure the effects of the medication. Sometimes I find that actually when you repeat the DEXA scan, it actually somehow enhances compliance because they can see an objective way that, my T-score is better. So then it sort of felt that, it may be a reason of why, you've got a whole long list there. Yeah.
So a colleague of mine did a really extensive review and looked at why people don't take their medicine. And actually the list is it's long and wide, but there are things like, people just accept that, maybe breaking a bone is just part of getting older. What's the point in taking drugs? I am asymptomatic. Remember, you are distressed when you break your bone, but after that's healed, then osteoporosis has got no symptoms. You don't know you're losing bone density, like high blood pressure. So don't take note. Side effects, to pay for it, traveling to get my prescription, maybe the doctor also feel, you also okay, you don't feel, and perhaps don't advocate for it as much. So the risk is, the reasons are plentiful, but maybe the important thing is to ask the person that's sat in front of you, why are you not taking the medication? And you might find some very interesting things or beliefs to why they decide not to persist with it.
Right. Okay. We actually do have some more questions, but because we are already running out of time, what we'll do is we'll try to answer some of these questions in the main group on the chat group, if possible. I may say that we'll need to end this chat, but rest assured we will try to answer your questions on the other group. Okay, and maybe everyone will just have to end this and go to the link that is been posted at the chat.